Well, on behalf of the Medical Alley Association and our partners for this webinar and content series, the Association of Black Cardiologists and the Preventive Cardiovascular Nurses Association, I am pleased to welcome you all to the third and final installment of our Race and Heart Disease in America series. I am your faithful moderator, Gabriella Spence, Federal Policy and Advocacy Manager here at Medical Alley. And to begin today's event, we have a special video message to share from Congressman Richard Neal, Chairman of the Ways and Means Committee. So let me set the table for this discussion, and then I will have my wonderful colleagues queue up the video for us. So as I mentioned, this is the third installment of our three-part series. Part 1 and 2 are podcasts, and if you haven't listened to them already, I highly recommend you do so. You can find them on our Medical Alley website or wherever you listen to podcasts. Part 1 explores the history behind health inequities in the United States and the role geographic and social determinants of health play in care equality. Part 2 delves into how current barriers in access to preventative care and timely interventions are greatly impacting populations of color and are key contributors to the state of heart health in the US. Each installment builds off the other, culminating in today's future forward conversation. So hopefully I'm going to queue up the video. We'll see if it's able to play. Again, this is a special video message from Congressman Richard Neal, Chairman of the Ways and Means Committee.
Good afternoon, everyone. I'd like to thank the Association of Black Cardiologists, the Preventive Cardiovascular Nurses Association, and Medical Alley for inviting me to share a few words with you and for putting together today's podcasts and webinars. Working in healthcare is stressful and challenging in the most normal of times, and we're now about to enter the second year of a devastating pandemic. Know that Americans are deeply grateful for the sacrifices you've made and the lives you've saved during this exceptionally difficult period. As terrible as COVID-19 has been for the entire nation, we know that its impacts have not been felt evenly, with people of color being at a higher risk of hospitalization and death compared to white Americans. In particular, Black Americans are 2.6 times more likely to be hospitalized and 1.9 times more likely to die from COVID-19. Likewise, Latino Americans are 2.5% and 2.1% times more likely to be hospitalized and die from COVID-19, respectively. That troubling trend became apparent early on in the pandemic, which is why in May of 2020, the first hearing of the Ways and Means Committee held during the COVID era, and in fact the first fully virtual hearing ever held in the history of the United States, Congress examined the disproportionate impact of the pandemic on communities of color. But we all know that the inequities that COVID has brought to the fore are not new. They existed in America long before this latest crisis struck. When I assumed the chairmanship of the Ways and Means Committee in 2019, I established the Rural and Underserved Communities Health Task Force to assess the challenge of delivering health care in rural and underserved areas, and to explore holistic policy options that could improve outcomes and care in these communities. Building off the task force efforts and taking into account the impacts of the pandemic, in 2020, the committee released a report entitled Left Out: Barriers to Health Equity for Rural and Underserved Communities, which highlighted the healthcare and non-healthcare factors that led to the worst healthcare outcomes for individuals residing in rural and underserved communities. Our work grew and evolved as we entered the 117th Congress, which we began in 2021. Last January, I launched the committee's Racial Equity Initiative, and that same month, the committee released its first-of-a-kind legislative framework that has guided our efforts to support health and economic equity. Legislatively, the House passed Build Back Better, and at the end of last year, we continue to push for it to reach President Biden's desk. I'm really proud of the work the committee has done to integrate equity principles into all of the policies we have advanced in Congress. In particular, I want to highlight the Pathways to Practice provision in Build Back Better, which the committee marked up in September of last year. The provision would make unprecedented investments to increase the number of physicians, training a new generation of doctors from rural and underserved communities, and reducing long-standing health inequities in those areas by incentivizing more physicians to practice in those communities. Not only would this provision be the largest investment in U.S. physician workforce in decades, but it would also make significant headway in tackling the paucity of physicians of color in the U.S. workforce. And we know from decades of research that cultural concordance results in better patient outcomes. This provision is yet one more reason we need to get Build Back Better done this year. I'd also like to highlight an additional particularly relevant undertaking of the committees. In October of last year, our majority staff published a report entitled Fact versus Fiction, Clinical Decision Support, Tools and Misuse of Race, which examines racial bias in medicine and the tools used to aid in clinical decision-making. While these tools can improve efficiency and the quality of care, they can also worsen health outcomes for patients of color who are pregnant, have cancer, suffer heart failure, or have end-stage renal disease. Thus, their ability to improve care and treatment of options is complicated by the reality that the methods and assumptions used to create the tools can themselves import harmful biases, ultimately exacerbating disparities. The committee's report included analysis of stakeholders' responses to a 2020 request for information that I issued to solicit input and recommendations on the matter. I greatly appreciate that the Association of Black Cardiologists responded to that RFI and provided valuable insights to inform our work. We are already beginning to see changes in this space, with stakeholders continuing to engage with us on this issue to broadly examine ways that technology can mitigate rather than exacerbate existing health disparities. I know that the discussions you're having today will be enlightening and productive. Thank you for all that you do, and I look forward to continuing to work together to improve.
He is a fantastic partner and advocate in this space, and we are incredibly fortunate that he made time to send us a video message since he wasn't able to make it. So let me introduce these wonderful faces you see before you. I have the great pleasure of being joined by Paige Bingham, Director of Boston Scientific's Close the Gap Initiative, Dr. Isilma V. Fergus, Director of Cardiovascular Disparities and Associate Professor of Clinical Medicine at Mount Sinai, Dr. Karen Larmour, Vice President of Clinical Development at FizzIQ, and Dr. Kevin Sneed, Senior Associate Vice President, Dean, and Professor at the University of South Florida. I am so excited to have you all here. Thank you for joining this discussion and for your pivotal work addressing these disparities.
Great to be here.
And they all have such wonderful backgrounds. I hope you guys appreciate them. So as Dr. Sneed pointed out in some of our prep discussions, I have a very ambitious agenda for us today. So we're just going to jump right in. Dr. Fergus, I'd like to start with you, and I want you to set the table for our conversation by identifying the important distinctions between equality and equity in healthcare.
First of all, let me say thank you so much for having me this afternoon on this very important webinar. I'm happy to be a representative for the Association of Black Cardiologists. I was a past president. These conversations are very important to, have and to continue and be interactive. And I'm happy to be with such an esteemed group of panelists. So the question to me was to explain the difference between equality and equity. And indeed, it is very important to be able to separate the two, because if that's not done, then that continues to contribute to the disparities that we see, even though people think that, both of them should really, alleviate or ameliorate that. So equality, I'm going to kind of break it down into maybe a little anecdotal stories. But first, I'll start with defining equality. Just means everybody gets the same piece of the pie. Equity means that everybody gets the piece of the pie that makes that outcome an equal outcome or an equitable outcome. So let's take the example of 3 boys, because this is research that has been done, and this slide is generated. Some may see it, may have seen it. But let's imagine there are 3 boys trying to look over a fence at a baseball field to see what's going on. You have a very tiny, short boy. You have a medium-sized boy who can see over the fence. The tiny, short boy is not able to see over the fence without something to elevate him. And then there's a very tall boy who can see way over the fence, okay? So Equality would mean giving each of them let's say a box, the same size box, for them to be able to see over the fence. Okay, so remember, the tall boy could have seen over the fence. The middle-sized boy could barely see, not well, and the little one couldn't see. If they all get the same box, the tall boy didn't need it because he could see anyway. The middle boy, the box helped him to see a little bit better, but the tiny boy, that box still didn't get him to see over the fence. So they all got an equal size box. Equity would mean giving the little boy 2 boxes. So now he's on the same level with everyone else. The middle-sized boy is seeing nicely with the 1 box, and the tall boy, who was seeing over the fence anyway, doesn't need a box. So that really is the crux of the matter, is that, you give people what they need. Not everybody needs the same thing. Not everybody needs an equal thing. And when it deals with populations, patients, et cetera, some people need to, or some populations need a little bit more in order to have the same or equal outcomes for all. So that is my definition and explanation. Thank you.
That was beautiful. I love a good anecdote. I'm an experiential learner, so you put me in those shoes and help me better understand it. And man, you set us up perfectly for this conversation. Thank you, Dr. Fergus. That was a big job to tackle.
Thank you.
I want to also just very briefly mention to the audience, if you have questions at any point in time that you'd love to hear our panelists answer, we're going to save a small portion at the end for Q&A. So please feel free to utilize the Q&A function below in your toolbar. For any questions we can't get to, we will answer via email in a follow-up later on. Dr. Sneed, I want to go to you next. And I want to talk about barriers in access to care, particularly when we're talking about pharmaceuticals. Increasingly, patients, physicians, and pharmacists alike must navigate these barriers. Can you identify a few of them for us, especially in the pharmaceutical space, and tell us about how these barriers can widen gaps in care disparities?
Gabriella, thank you very much for that question. And I share Dr. Fergus and her enthusiasm for such really a great panel. What you're asking is a very important question, because when it comes to pharmaceuticals, we're talking about the complete industry that goes all the way from manufacturing to distribution to people and communities. And so one of the main things that winds up happening from a true access standpoint, number one, just having access to a knowledgeable person that can share your lack of understanding of what the medications are for. Very often, I hear it all the time. And by the way, I still practice, even as a dean and administrator here in our Department of Family Medicine here at the University of South Florida as a cardiometabolic syndrome specialist. I see a lot of diabetic patients. I saw them this morning. It's very important that when a physician or a prescriber, a nurse practitioner, PA, when they prescribe a medication, they may tell them what it's for, but when they go to pick up the medication, they may not either remember, they may not have understood, they may have been a number of other challenges that were going on during the encounter that may actually prevent them from truly understanding what the medication is for and the most appropriate way to take it. So really having a pharmacist and having access to the appropriate people and information is one barrier that we find all the time. Another barrier, and I think Dr. Fergus did a beautiful job in talking about equity and the difference between equity and equality. Depending on where people live, they may find themselves in what we call a pharmacy desert, a term that many people have not heard before. It may, you may not live near a pharmacy. There may not be a pharmacy on every corner like we have in a metropolitan area, where you may have 2 or 3 pharmacies all competing for the same corner. But if you live in a more rural area, it may be 4 or 5 miles away, and you may not have the transportation, the access, or the means to get there at all times. And then actual cost of medication can be a really intense barrier for many people. I find it happening with many of our Medicare Part D patients, or just insurance overall. Medications, if you are a metabolic syndrome patient that has multiple conditions, you may require anywhere from 3 to 5 or 6 medications, and you have to pay a copay on each one of them. very often people may find themselves trying to find a way to make a decision. Should I pay for medication, or do I go out and buy groceries, or I have to not put as much gas in my car, or other costs associated with that. And also around cost, very quickly, some of the newer medications that we know can be very beneficial in keeping people out of the hospital, keeping them out of going to emergency rooms and so on and so forth. Very often the costs are just prohibitive, even if they are subsidized by an insurance plan. So there are various challenges that we all have in the healthcare system, whether you're a physician, nurse practitioner, or otherwise, that can prevent a person from having a very successful or optimized medication outcome. And we all have to work together to try and overcome them.
Absolutely. Yeah. Dr. Larmour, I've got a question for you next, but I want to open it up to you and Paige. Is there anything you guys wanted to add from your perspectives?
Sure, thank you. I come at this although I work for a digital health tech company, I come at it as a nurse practitioner, having worked for many years in cardiovascular disease, and I am coming via the Preventive Cardiovascular Nurses Association. So our lens is to look at this through prevention, which after Dr. Fergus's comments and Dr. Sneed's comments, it just made me think about, the gaps that we have are so highlighted from the beginning to end of the healthcare system. Our system right now is really focused on the acutely ill and how do we manage this when someone gets sick, and do I have the resources to, as Dr. Sneed mentioned, afford the medications that are going to treat my illness, or do I have those boxes, so to speak, that are going to elevate me to where I get the same care that every other person gets, that I get the equitable care. And I think we all know that does not exist right now. A lot of it's because it's focused on hospital-based care that is immensely expensive and not focused on preventive care that traditionally and usually is less expensive and could even be behavior driven. So we talk about the gaps in the system. These are the things I focus on. These are not new things. It's not groundbreaking that I'm bringing this up. But what is interesting is during the last 2 years, during COVID, there was the brightest spotlight put right on that. And so let's think about those folks that were hit the hardest with COVID. It was those marginalized, vulnerable populations, the African American community and the Latinx community that really took the brunt of this because they don't have access to the same system that traditionally non-Latinx whites do. And that's where the gap is. So it's fixing the health system itself, and then in that process, providing equity so that those that are under-resourced can reach for the same goal of health that everyone else is able to do.
Well, and Gabrielle, I would love to build on that. And thank you for the wonderful setup, Dr. Larmour, and also Dr. Ferdinand in the very first podcast of this series. Did a wonderful job of outlining the death gap, the white-black gap in mortality. And it really resonates, especially coming from Boston Scientific Cardiovascular Disease and broader medical specialty company, but emphasis on specialty and the therapies that people so often are not getting. And just recognizing COVID was an exacerbation of an existing systemic challenge, and the recognition that we really are missing people receiving equitable care, resulting in even this event was 1 in 4 Americans are dying of heart disease, and 30% more Black Americans are dying of heart disease above and beyond their non-Hispanic white counterpart. So it is a crisis that COVID has luckily shined an even brighter light on. And I'm so thankful for this panel of esteemed guests because I know this group is making a difference. Thank you.
I almost feel guilty we've only done this in a 3-part series because this could just be ongoing conversations that just 24/7 keep rolling. I don't know who would want to come on 24/7, but I would find somebody. I want to talk about bridging those care gaps, but I want to take a little bit of a sidestep and talk about clinical trials because I think it's not really an area, it's an area our medical ally community is really involved in, but I don't know that I've really come across it in a lot of these discussions. So Dr. Larmour, I'm going to go back to you. It seems like a really basic question, but it's really helpful to know why is increasing diversity in our clinical trials so important? And how do we reach more diverse populations and ultimately get them to participate?
Yeah, thanks, Paige, for that question. I'm going to take everybody back to Research 101. And so when you think about doing a clinical trial or research, we think about the participants. We used to call them subjects, the participants in the study, and what those participants represent. So there's a concept in research called generalizability. Now, if we want to research a therapy or a medication, we'd like to know that it works in all people, but cost-wise, you can't research every person that might be treated by it. So what we do is we do a statistical analysis to figure out how many people can be part of this study that will give us an outcome that we believe is valid, that is truthful, and still be cost-effective to do so. So over the decades that we've done clinical research, what we have found is that most of the people in what we call that sample have been white. And not only white, they're usually white men. And so then our question is, well, is it really generalizable to someone who's not a man, who's not white? Well, I think it's probably not generalizable. And so our mission now is to include a more diverse population in our sample sizes so that we can truly say with a greater degree of certainty that when we approve a therapeutic, that this therapeutic will work in a diverse sample set. Now, the balance of that, again, is always the cost and size continuum. But what I have found is that most large pharma and device partners recognize this now, and they have made it part of their mandate to move forward and assure that there is diversity in their sample sets. In fact, the NIH, with the largest funding organization for clinical trials in the United States, has you complete an actual portion of all their grant applications that forces you to demonstrate how you're being inclusive. So there's part government regulation, and there's part, we want to be smart and good and good business partners in how we're developing our therapeutics so that it impacts all people that may use that product. And maybe, Paige may even have more to say about that since she comes from that area, but I have found that we're moving in that direction. Not quite perfectly there yet, but moving there.
That's really helpful to know. Paige, do you want to comment on that?
Yes, thank you. I really appreciate that setup, Dr. Larmour. And yes, we did a wonderful study in 2017 was the publication, Mount Sinai, and Dr. Roxana Moran was one of the lead authors with regards to the Platinum Diversity Trial. And it was a trial that intentionally pursued women and people of color, race and ethnic diversity in the trial. Not always do you get a chance and opportunity to do that exceptional work. So then the question is, how do you bring it into everyday trials, which is, I think, what Dr. Larmour was really bringing that forward beyond NIH, beyond industry standards. It's just human goodness, humankind practicality. So I know one of the trials we're working with right now within Boston Scientific is drug-eluting stents. Peripheral artery disease is a crisis in our country, specifically because there's a Black amputation epidemic, and 3 times the rate of Black individuals end up with a lower extremity amputation. So that is a need that we have, and there was recognition by the Chief Medical Officer for our peripheral interventions group, which is Dr. Michael Jaff, who spoke on a roundtable fireside chat last year at this time, really highlighting the fact that clinical trial will have 40% women and 40% race and ethnic diversity, so people of color. And that's being done intentionally because we know that we really do need to step up our work. We need to be in our trial design, in the strategy setting. We need to be recognizing who should be part of the trials. We need to have our steering committees inclusive of diverse physicians. So thank you, American Association of Black Cardiologists. Through that conversation and connection, we have Dr. Lee Kirksey from the Cleveland Clinic on the steering committee. And that makes such a difference when you get into site selections and you're determining where in the United States should we be going, who has the diversity already in their patient population. And then you step forward, actually in your IRB packet, you intentionally put education materials for your patients that is representative of the community you want to reach. So those are such critical points to then make that enrollment go well and really see the diversity in patient participants that we all are hoping for.
Oh, that's so good. You've actually, I'm sorry, go ahead, Dr.
No, I was just going to say that I appreciate so much what Paige brought up. And I think you alluded to it at the end there that, one thing is that I hope that all researchers are required to be trained in some of these ethical standards around doing research, but we're not naive about the history of research, whether it's reflection of Tuskegee or Henrietta Lacks, and I hope people will look, if you're unaware of what happened in those situations, that you do become aware of that. Because there's also a bidirectional reason why we don't have diverse populations, because we've frankly done them wrong. And there's a built up culture of fear or distrust of clinical trials and even healthcare because of what's happened historically. So I think some of Paige's comments about having diverse panels and institutional review boards that must review all the research should be diverse and represent the community as well. And then continue to do the good work of education and really community partnerships. It's really the partnerships where the community feels that they are part of that research, and then that information is fed back to the community. We don't just abandon them after the trial is done. Again, we saw it with COVID, with the vaccines and vaccine hesitancy to be involved in the vaccine study, rightly so. So we can do better. We can do better, need to understand our history and then move forward based on that.
Yeah, Dr. Larmour, thank you so much. Dr. Fergus, I wonder if you can help us bridge this conversational divide by talking about how we can bridge these care gaps through partnership. There are so many elements of this I want to talk to you about, especially with like the workforce piece, but we're already well into time, and I'm hungry for a lot of other questions. So
yes,
and about that role, just go ahead.
So I was going to say exactly what Dr. Larmour said when she went back to give her rebuttal, because, and I'll lead into your question, but when you reach into communities to try and get them involved with clinical trials and research, exactly that. Some people refer right back to Tuskegee and Henrietta Lacks, and it is something that definitely remains as a sort of stain or stench within communities. You have to regain trust. So I like what Paige is talking about in terms of just increasing the diversity, not just with, the trialists, but, everyone on the team, and also recognizing that we have to have inroads into the community. So you talked about community organizations, but I think we should also reach out to the primary care practitioners, those healthcare providers who the patients trust, that they know who would not send them into a situation that would harm them. So, I think so. A lot of the primary care practitioners, they're trying to get their daily bread and butter. They're not research trialists. They don't know anything about clinical trials. But I have gone into the community and I've found that a lot of those primary care practitioners, they don't want to let go of their patients, because when they go into the big institutions and into the research, they don't come back. So one of the mechanisms that needs to be implemented is to figure out how do we get those patients back to the primary health care providers and have them, be a part of the dialogue. Also, another important thing is the family members, right? So family members are going to be saying, don't take that or don't do that, because remember what happened back then? They're just experimenting on you. So again, building that trust. So your question to me was, how do we bridge that gap? And how do we, so you're asking about relationships between organizations, et cetera. But so organizations like the Association of Black Cardiologists, the Black nurses, and also any type of Hispanic or any other, unrepresented groups, those organizations, the Hispanic Medical Association. And now I'm focusing a lot on South Asians or immigrants of Asian origin, because they are also disenfranchised and also they're high-risk populations. And oftentimes they're not talked about and not represented in clinical trials. They're not. Now, when you look at the demographics in the United States, you see about 13% African Americans, 17% Hispanics, of rapidly growing group of Asian Americans. That needs to be reflected in the clinical trials in order to be generalizable, as Dr. Larmour said. So these organizations, I salute them, but we also need to engage with other entities that participants, patients, community, if you will, engage with. So besides these organized types of organizations like ABC, et cetera, you need to reach out. They're the Greek organizations, the sororities, the fraternities that people belong to, that they trust. And members of sororities and fraternities are college graduates, but they're large groups. So they understand, they get it, they want to be involved, and they themselves can help to spread the word, they can help to recruit, they can help to engage and do all that. So I think we need to pay a little bit more attention to that, as well as the churches, the mosques, the places where people worship. Those are very important too. So maybe creating some sort of a collaboration or liaison, and maybe companies like Boston Scientific in Closing the Gap can, engage with getting some, dollars out there to really get these other groups involved. Because I promise you, doing that, you will have a lot more engagement, education, outreach, and understanding, of getting our messages out and also getting people enrolled in clinical trials.
Yeah, absolutely. Sorry, Paige, I saw you just unmuted. Go ahead.
Well, Dr. Fergus, you just are, singing just a wonderful song that is music to our ears, because I agree. And I've got to thank you. I know you were part of the Black Health Matters event that we co-sponsored in May of last year in New York City. We partnered with around COVID with Siemens Healthineers. And we intentionally went into that market saying, we need to be providing a space for collective action to bring together the healthcare systems that are fighting for the lives of individuals in that community. And we really do partner with Black Health Matters with the intention of creating that space. They have the relationships with the Divine Nine. They have the relationships, or reach into the relationships of the community. So when we did it in Detroit, they reached out to the Motown Museum. They reached out to the churches in the community, and then brought together the healthcare providers so that there's a shared space where we really can create a collective voice of change. And in that, we include a clinical trials session, which you probably know all too well, Dr. Fergus. The beauty of Black Health Matters is really trying to address inequities on all fronts. And so, yes, I sing your praises, and we look forward to doing it in Atlanta next, really intentionally with a Black fraternity. So that'll be in April, and we're excited to continue the journey. And I got to thank my leader, Camille Chang Gilmore, our Chief Diversity, Equity, and Inclusion Officer, for her advocacy of let's connect with those leadership groups that are trusted in the community, that are making a difference, and that have a service mission. So it's not just to benefit themselves, it's to reach into the community and build that service. So thank you.
Yes. Dr. Sneed, I'm calling on you next. I have not forgotten about you. I know I haven't called on you yet, but I've got a number of questions for you. So get ready to monologue. First, I want your perspective on this, because I know you're active in leading a group called We Care, and correct me if I got this wrong, but it stands for Work Group Enhancing Community Advocacy and Research Engagement. Tell me about this community. Tell me about some methods you've used successfully to build trust within communities.
Thank you for that question. And again, in full disclosure, I too am a very active member with the Association of Black Cardiologists, even though I'm a non-cardiologist. And so for all of our non-cardiologists out there, we welcome all of you to come and join forces with us as we build bridges into the community. We Care really came about as a result of an NIH grant that I helped to write and participate in. And And what we were doing really is everything that Dr. Fergus talked about and Dr. Larmour, where we wanted to go out into the community and begin educating to overcome the stigma of Tuskegee experiment and overcome the Henrietta Lacks and try to break the cycle of one generation telling another younger generation to avoid clinical trials and clinical research overall. Two things that we did. Number one, we built a community research review committee. Just prior to coming on here, I was talking, and we're having a meeting next week. It really is a bridge of building researchers to the community, but the people on that committee are all people from the communities that we're trying to target. They are non-clinicians. Many of them are non-college graduate individuals, but they represent the best of the community. And we wanted to be able to bring researchers to the community to interface and talk about their research, and then be open to questions from the community about very important topics, including equity. So that's one thing. Number two, we went out and we built a very meaningful relationship with an organization called Reach Up Incorporated. And it began prior to the pandemic. And right when we were about to launch all of our initiatives out in the community, the pandemic hit. But because we had already been working with that particular group, we were able to leverage that relationship. And they know everybody here in the Tampa Bay area and across Florida and even nationally. We were able to leverage that into multiple COVID vaccine drives. I now personally have done well over 100 community COVID-19 educational programs, overwhelmingly via Zoom, and we use their Zoom platform. And so I think making sure that we build authentic relationships. And even in We Care, we repaired relationships between the primary care physicians out in the community and the research institutions that we have here in the Bay Area. Again, I think Dr. Fergus was 100% correct in that in the old days, if you referred your patient to a clinical trial, you might not get them back. Well, now we don't allow that to happen. We include them in the research. And so we have a number of different tactics. We have employed, Dr. Fergus, by the way, everything you mentioned with every community partner that you mentioned. You were warming my heart to hear you mention all of the different groups. And I'm saying, well, we must be doing it right because, I checked every box you mentioned. And so those are just some of the tactics that we have used to really get out into the community and spread the word about clinical research. And by the way, we were number 2 per capita in the entire state of Florida for the number of African Americans that were vaccinated. And a big part of what people came back and told us was because of all the educational programs that we did.
Thank you doesn't feel like a powerful enough word, but thank you. I mean, each one of the panelists are a rock star audience, but Dr. Sneed, I got to give you an insane props. Thank you so much for the work you've done. That's incredible and makes a real impact. It's that sitting down, it's answering questions, it's making yourself available. I wish everybody had that opportunity, not just to talk with you, but to talk to a trusted medical professional who's there, not just to talk to the community and walk right out and go back to work, but comes back, keeps answering questions over and over again, even if they're the same ones. I also want to point out, thank you. You've had a very busy morning. You were seeing patients, you were talking to your committee there. Now you're on a webinar. I mean, that's very impressive. Thank you for your time. I want you to help me transition into the next section, which I want to talk about innovative technologies in this space. I know it's an interest of yours. Talk to us about what you're seeing. Any trends? What are you seeing on the forefront? Where are you seeing a lot of these innovations crop up in industry specific, like care delivery, at home, devices, pharmacy? Give us some insights.
Well, even though I'm an academic, I'm a techie, and I always have been.
Sorry, I think you need to stop saying "even though" because we get it. You wear a lot of hats. You got a lot of interests. So about 8 years ago, I really did immerse at a very high level into the mobile health technology field. Began working with a futurist group around the country. And really thought by now, 8 years later, we would have had we would have been further along in terms of immersion of, mobile and Bluetooth technology and being directly in the hands of more consumers. So it hasn't happened.
So what we're transitioning to now, and what I'm putting a large amount of work into, are building platforms that will now allow that to happen, a la Steve Jobs in kind of an Apple way, that will make it very easy for multiple people in the communities to really become what we're calling citizen scientists, where they really begin to help us collect data. They participate in the data, they interpret the data, they have the data at their hands. And then right along with us, we can begin an educational program of know your numbers. We found that about 90% of US adults now have a mobile phone, and about 70% of those now have a smartphone. So we need to leverage that. So I think the platform development is going to be the next big thing that will occur. And I can't tell you enough how excited I am. And I'm working with companies right now, Fortune 500 companies. But I'm really excited that we're having a portion of the infrastructure bill that will go across the entire country that will begin to beam Wi-Fi across communities that had not had it before. And I've told people, if I can beam a Wi-Fi signal across a community, I can overcome many of the access to healthcare barriers that they've had over time. And so we're working in a number of different areas. And so over the next 5 years, I think you're going to see a big boom in terms of having multiple platforms that can receive that information, augment what I call augmented reality or artificial intelligence, augmented intelligence, being able to interpret and then provide feedback to all of the providers in their true patient-centered care model. And so I think ABC has been at the forefront, to be perfectly honest, in terms of interprofessional care, bringing multiple collaborators on. And that's how we're going to hopefully overcome many of the access barriers that we have had for many decades now, using technology to overcome that.
Oh, fantastic. Citizen scientist, if that's a badge or some sort of honorary title I can get, sign me up. I will do whatever you need me to do.
You signed up.
Oh, yes, fantastic. Audience, you can sign up too. Just contact Dr. Sneed. Dr. Larmour, this is your bread and butter, the AI piece. He set you up really nicely for this question.
He did.
Give us your perspective on this. Tell us about what FizzIQ is up to.
Yeah, this is great. And Dr. Sneed is not a paid spokesperson for FizzIQ, but he could be. So what we do at FizzIQ, we are really that platform that Dr. Sneed referenced. We are a digital health company. And what we do is we have analytics that we apply to data that comes in through biosensors or sensors. And so what we do is we have an end-to-end system basically that uses, we use medical grade biosensors. So it's not a Fitbit or an iWatch, but it's actually medical grade sensors that are out there. We currently do a lot of work with a very small patch that's put on the chest where we receive the ECG or heart rate and data signals through that patch. It's transmitted through Bluetooth technology to your either the Android phone that we provide or to the person's own device, then to the cloud. And that's where our magic, our analytics are applied. And when we talk about AI, that's what we really use. So we use two different types of AI. One AI is sort of the broad term of artificial intelligence, where we've taken, or any organization, if you've used an Alexa, right, and it learns your voice, that's AI. Or if you any kind of voice recognition on a phone app, that's AI. And what AI requires is huge amounts of data. So let's talk about physiologic data, right? If you've got a group of people in a health system or being remotely monitored, we take that huge data lake, we have applied a machine learning technology or AI against that, and we learn to predict things. So we may learn who's most likely to get readmitted in the hospital, who's most likely to get sick from sepsis. And the idea is the sooner you can predict it, the sooner you can act on it, or you may develop strategies to prevent it altogether. So that seems like a win-win. And I will say that I think it is. Of course, FizzIQ believes that's where the future is. I would say the flip side of that, in the context of what we're talking about right now, is think about our discussion about generalizability. Whose data is that's in those data lakes? If it's vastly white males or white individuals in general, does it really represent the AI that we need to represent a diverse community? And it may not even be that it's that someone that's African American or Latinx is so physiologically different from me, but what is different, is what the social determinants that have impacted their health that comes to the table. So by the time their physiologic data gets dumped into this data lake, they're already bringing with them the representations of those inequities that have happened throughout the years. It's absolutely fascinating. And I'm gonna read a quote. I wrote it down here. It's in an article that I referenced that the audience can get to, but Linda Norderling writes about this in Nature, and she says, this revolution hinges on the data that are available for these tools to learn from those mirror the unequal health system we see today. So while it's a great tool, it could mirror the inequities. Now, I'll just say one more thing about that, we're always working between that tension of having tons of data and what is that data pool representing. That we just wrapped earlier this year or late last year, wrapped a big study looking at COVID and having a predictive COVID decompensation index. And that was funded by the NIH. And we were able to predict COVID decompensation several days before someone got really sick. So they could be at home, have the sensor on, nurses would be watching a portal, an alert would come up, and we figured out that alert could show up several days before what we didn't want is people to go home and die, which is what we saw at the beginning of COVID. So we wanted to be able to predict that. What we did was we partnered with an institution, University of Illinois Health, that is primarily serves a marginalized, underserved population in the Chicagoland area, and our population well overrepresented African Americans and the Latinx community. Now, the downside of that is, does the CDI work for people that are not Latinx and African American? And this is the tension that we work with all the time with AI. I would just say that finally in this, that data is king. It's the new oil of this century. And I couldn't agree more with Dr. Sneed. It's AI and how it's impacting us on a healthcare level is just kind of bubbling right underneath the surface. But it will be the biggest change that happens in how we care for people and how we care for people in a better way. And I know we're going to talk more about how do we manage that and how do we control it, but it is the future. And I know at FizzIQ, we're terribly excited about the advances that we're making both in clinical trials and life sciences, but also in healthcare delivery.
Dr. Larmour, I just want to take 20 seconds and really compliment you and your company because you talked about providing the community with the devices. I get that question all the time. How are we going to be able to afford it? Well, I think every company should want to afford it because
that's right.
Data is far more valuable than anything else.
That's exactly right.
So I couldn't agree with you more, and I was really warmed to hear you mention that part. And I think moving forward, we need to provide many more of these tools for people in every community, regardless of socioeconomic status, that can provide them with data, but make sure that they control their ability to access and provide it.
That's right.
Because I just wanted to add that part in very quickly.
Thank you. Without that, we continue to support the digital data gap. So we provide a kit that has the Android phone, the sensors, and the cell service plan with it, because we can't assume that everybody has wireless or a cell service plan.
Well, help me make sure that Washington, D.C. push Wi-Fi across every community, regardless.
Yes, you better believe
regardless.
it.
So, thank you very much for your advocacy there.
Thank you.
Well, I'm hoping that just takes off and goes all across the United States and to these pockets of where you have immigrants and underserved,
that's right.
representatives. So I'm hoping to see that. That's just excellent work, and I love it. And
Thank
that's
you.
Truly generalizable what you did, right? So hopefully
it is.
That just spreads out across the U.S. because that's going to be very important. I do agree with you. In the direction we're going, AI is really the future. It's already here. People are using.
Oh, I'm sorry. Right. Think about it for rural health as well. The lack of access in rural health. I mean, we enrolled people from 4 different geographies, and many out in Utah, downstate Illinois, which is an underserved area. But anyway, I can go on about what I do.
Yeah, no, but this is
I have a
excellent.
passion
Thank
for
you.
it. Thank you.
Thank you for
We
your
just a
excellent work.
webinar with Dr. Larmour, and she just talks. I actually don't ask her any questions. She just kind of
No, just that's my coworkers. Just let her ramble.
I love it. It's not a ramble though. You've got a destination
great.
you're getting to, and then you're also weaving over here. It's very dynamic. It's very dynamic. So Dr. Seed, you mentioned the work in DC. I want to poll everybody. So jump in when you have something you want to say. But what is the role of government in this conversation? Are there regulatory, legislative changes? What change do you want to see? What role do you want federal, state, local government to play in these spaces? And again, feel free to jump in, whoever wants to go first.
I'll jump in very quickly. Many people have it wrong, and we've come to a point in the country where we kind of have it backwards. The role of government really is to protect the people, to protect society and protect civilization. And we need to promulgate that protection in any way possible without, again, in our country, impeding on people's freedoms. And I know that's been a big friction point across the entire country. But when it comes to health, health is your wealth. And so we need the federal government, we need state government, we need local government and municipalities everywhere to get more engaged in preventive health and public health. And really, because the pandemic unveiled really the stench of health inequities all across the entire country. And when we talk health inequity, I'm not talking about just racial. I mean, in a whole bunch of different areas. And so if any government officials are out there listening, we need more assistance in terms of prevention for the next pandemic when it comes in less than a 5-year period.
I agree. I think that we need to stop politicizing health. And that has happened tremendously with COVID. And we need to have bipartisan involvement. It's not us against them. It's not Republicans versus Democrats versus independents. Let's put our collective heads together to ensure what could be done as a whole across the entire nation. So I find that there's a lot of time being spent, and all these different issues are very important, right? But without health, you have nothing. Martin Luther King stated, and I don't want to screw up his quote, but if all forms of inequity, inequity as it relates to health is the worst, right? And I'm kind of like putting in my own words. But the point is that as we continue these, these partisan politics, where it comes to, vaccines or not and medications, we know that some of the treatments that has been put forward are clearly not correct, but to maintain, an appearance within a particular party, things are being, put forward. What I think that we need to have somehow, I don't know how to get through the groups, but to have a bipartisan involvement, to have our CMOs, to have everyone sort of involved together. And let me give you an example. When you have someone, and I'm not pushing any particular party, and I'm not going to even say the name, but the Association of Black Cardiologists has been involved with trying to get some of this issues addressed through the Spirit of the Heart programs, where we just don't do like sort of community outreach. It goes into the churches, but there's always a leaders forum where we focus on the political leaders, right? Because they're the ones who shape the policies and the legislation as it relates to a lot of this. And I've actually seen very good outcomes. And to give you a little bit of an example, in the New York area, one particular person or senator that we reached out to, based on that involvement, he put forward a lot of effort into engaging. This was for prevention or management of hypertension. So a whole lot of attention was focused on salt sensitivity, salt intake, involving a lot of the clinics, a lot of the private practitioners, and that was a successful small thing on a small level, but I'm talking from a grassroots level all the way up. Another Spirit of the Heart program, a particular person who's now a mayor of a major New York, a major city, got involved, lost 100 pounds, is eating well, and now part of the platform is to ensure healthy eating and healthy behavior. So I think however you can get it get that in there, whether it's from a macroscopic level down to, a grassroots local level. It's very, very important. So I know Camille is listening in, and she's done a lot of advocacy on behalf of the Association of Black Cardiologists, and she's in Washington, D.C. But that's something that we really need to focus on, because I think if government is not involved, we're going to really have a hard time, really achieving the goals that we're setting out to achieve.
Let me just say, and I want to point the page in Boston Scientific just for a quick moment. When people ask the question, can we afford to do it? Well, if you really think about it, our country is too small not to do it. We only have 330 million people. It sounds like a lot, but when you compare that to, some of the Asian countries that have 1.2 and 1.3 billion people, we can't afford not to invest in the health of our country. We need everybody to be able to be a productive citizen. And I know that Boston Scientific and their partnership that they've had with us is really focused and they can articulate that. So, Dr. Fergus, I could not agree with you more. We have to bring politics out of it, and we have to really come together as Americans and do everything we can to create a healthier environment moving forward.
I would really chime in on that, the multilateral work that needs to happen. So it is that industry, government, nonprofit, and the advocacy groups that really, and ABC is a great example of really getting out there and advocating. I know one of the places that we've seen a huge difference is with the Congressional Black Conference and being able to be part of their annual leadership meeting and being able to put forward a panel that really talks about the Black amputation epidemic, that talks about that 3 times, and then that recognizes Representative Donald Payne from New Jersey, who put forward the Amputation and Compassion Act that really we hope comes to fruition, because at some point you stop hoping, you stop being your microcosm, and you recognize that where I see government is it's the collective good. It is how do we bring forward all the things that have been tried, all the things that are known, all that data is telling us, and actually bring it forward into the rights and the rewards that we receive. As Dr. Mira said in the last session, where she commented, your health is your greatest asset. How do we come forward as Americans and say it's worth it for all?
Paige, thank you for quoting her on that. That was, there's a couple of one-liners she had in there, and they play on a loop in my head every so often. And it is, those are good sticking points. Dr. Larmour, bring us home. What do you got?
Sure. Yeah. I think that, staying focused on the AI, machine learning, big data perspective of things. I think like any government regulation or ethics or laws, it's lagging behind where we are with AI and big data and people's ownership of their data. And again, there are whole conferences on that, but I think that government needs to partner with industry, partner with the really smart people that know what's going on with AI, so they can become informed about making laws and regulations around AI and data, not to handcuff organizations. I'll give you an example. With the FDA, they actually recently changed a law that said every time you come out with a new algorithm, you don't have to get that algorithm cleared every time if it's making the data set better and better. Because in order to get an algorithm cleared by the FDA, the process, it's similar to the drug approval process. It could take years, could take 9 months to get an algorithm approved before you can start using it. And we need that to be shorter. So getting the intellectual input behind that to say, let's take the handcuffs off this, but let's look more closely at what's happening with the free range, rampant gathering of data that we don't even, and I'm not paranoid about it. Believe me, I'm on all the big platforms posting all the time, and I'm sure everybody knows what my face is, but I do think that most people are, especially in institutions that they trust, that they're not quite aware how much of their data gets pulled, and that's their data to own. And maybe they should start getting paid for that.
That's fantastic. Thank you. Thank you all for your perspective. I want to give you an opportunity to speak Not that you haven't already, but speak directly to our audience. We've got business leaders. This will get shared with policymakers. We've got device and biotech and startups and Fortune 500s. What do you want them to walk away with? Finishing off this series from where we started, looking at the historical backgrounds of these health disparities to the current situation in the US to what we can do and looking forward. What do you want them to know? And again, I'll open it up to anybody who wants to start. Just eager to let you speak directly to our audience and give them some action items.
I'm happy to start.
I would say you can just even go in reverse.
I was just on a webinar, luckily enough to attend it yesterday or the day before, and I encourage everyone to look at Ruha Benjamin's work in AI and technology. She's a researcher and expert in this space, but I want to quote her too, where she says, the ease of inclusion for some increases marginalization and exclusion for others. So where we have advanced in AI and machine learning and some of these technologies and makes it great for some, it's actually reinforcing the barriers for others if we don't include diversity in what we're doing in AI. So it's important that we still focus on as Dr. Fergus mentioned, Dr. Sneed, Paige mentioned, the grassroots elements of what creates barriers to care and what creates segregation and marginalization. Those undercurrents need to still be addressed because otherwise they're built into the AI and then it self-perpetuates how we use that. So I would just say, increase your awareness. This field is changing fast, and if you don't know a lot about it, get in and do your reading and stay up on it because it's coming.
Dr. Sneed, I know you reached to unmute and Dr. Larmour beat you to it. Would you like to go next?
Yeah, I'll be very quickly. I know we're at the hour, but I would encourage all of our viewers to really think about the level of impact that we need to make. The pandemic, again, has shown all of us how bad things can be. And to be perfectly honest, I just want to put the context I tell many groups. Imagine if the pandemic had started off with the Delta variant, the most deadly of the variants that we've actually encountered up to this point. If it had started there, and then imagine that we start there 5 years from now, we have an opportunity right now to create major impact in the way of health, applying technology in a very equitable manner across all communities across the country. But that's going to start with people that are being viewed, that are viewing this webinar today. So my big term for 2022 is impact. I want impact in everything I do. I want it to impact people in a major way. And I hope that will be infectious, pun intended, for all of you to want to do the very same thing.
Dr. Fergus, perfect. You read my mind. I don't know how you pulled that off, but go for it.
Oh, so I echo what was just stated by Dr. Sneed and Dr. Larmour. I just want to be very practical here. And I know we have a wide array of people listening in. Even before the pandemic, as it relates to morbidity and mortality for cardiovascular disease, we saw an improvement overall in the entire country, but when you broke it down and you actually separated it into the ethnic minority groups, you see a plateau, even worsening in some cases, say for African Americans and Hispanics. And I know we don't have that great data to that extent with South Asians. I can tell you, and this was just shared here already, the groups that had the worst outcomes for COVID were those same groups. So what we're seeing is a decrease, I'm sure, in life expectancy across those groups, okay? When there's something terrible happening, everybody pays attention, right? They may not act on it, but at least they're paying attention. When that kind of settles down, people go back to their merry way, okay? What we need to do is to keep that conversation going, keep that awareness going, recognizing that in this great country where there's so many resources and information and wealth and everything, disparities should not exist. Everyone should have an equal opportunity, equal access Now, how are we going to figure out equity versus equality? What are we going to do? What can be done? How can we reach people where they are? A lot already is being done with the AI, and I really love the whole thing with the smartphones. But I can tell you that some of the groups, we have to figure out, what are they doing? Where do they get the information from above and beyond what we're already doing? Social media, television, okay? Those are avenues for reaching people. People spend a lot of time looking at all kinds of shows, movies, this, that, or the other. How can we, move into that arena, getting information there, using the smartphone, using AI, but really keeping that conversation and that awareness going. Just because we have now come to a point where we feel very comfortable about COVID, there are other things that are going to happen and come. Things are cyclical, right? So beyond an acute infectious problem, we still have the non-infectious disease issues, these chronic issues that are being dealt with. We cannot forget that. So let's continue to have these conversations. Let's continue to find innovative ways of getting really truly into the mindset of our entire population and keep that conversation going. And let's continue to build, new innovative ways that really resonate with everyone, from immigrants to the wealthiest, as far as what can be done to keep that conversation going. So work to be done. I applaud you on putting forward this conference, because of course it gets the conversation out. But I can tell you that the people who are listening, of course, hopefully they're going to take action and move on. But we need to figure out, how do we get out? That same grassroots conversation comes up again. How do we get this information to somebody out there right now who's more concerned with, I have to work 2 jobs to feed my family, right? I don't care, but I just want to get some food on the table. How do we get that information out to those people? And that's what we need to really work on. So that's my call to action, is let's continue this work, but let's figure out how to reach out there to truly at a grassroots level, beyond the college educated, beyond, churches, beyond just simple people who are just trying to survive. How do we get out to them? And that's my call to action.
It's actually a call to action. Conversations are great, but we need to actually act. We need to make some forward movement towards it. Paige, bring us home. Share your perspective.
Oh my goodness.
A stellar conversation. I'll compliment you guys in a minute, but go ahead.
Oh, for sure. Dr. Sneed, Fergus, and Larmour, it's been just a joy. And there are so many more parts to this conversation I would love to have. Our website is called fightforhealthequity.com. Yes, we've been Close the Gap for 18 years. There is a reason why we are getting nattier, more engaged to really call the racism question, to really ask about the institutional biases that are harming our society. And we're focused on the health equity ones. And while we talked about clinical trials, and that's where often I think when you're coming from industry, people know you're investing money. And so the questions go into that space. And yet we really, as a team, are focused on clinical trials, but more importantly, from R&D into practice. And so that's where the group that I work with really does focus on, how do we bring data, not just into a clinical trial setting, but how do we bring data into the local catchment area, primary service area of the providers that are out there across the United States that are providing cardiovascular care. And how do we call them into conversation about what is health equity for you? And what does it mean if you were to put an action plan to do different for the community that you serve, recognizing that there are these disparities that we can actually showcase, we can share with you from the claims-based data that we know is happening, and then call the question of, how do you improve and how do you get better? So that's where, again, we bring in resources to do that. We bring in the education of peers, peer-to-peer provider education, as well as patient education. But by no means do we mean to hang this burden on the patient, on the individual that's not getting access, and expect them to navigate the complexity of a broken healthcare system. So call to action, fight for health equity, and do it with all your heart, because there is a crisis at foot and we need to fix it.
Oh, beautiful. With the utmost sincerity, thank you, panelists, for volunteering your expertise and your time to better equip us, each of us, to combat these health inequities. Thank you guys. Thank you all. I want to also thank our partners in this series, the Association of Black Cardiologists and the Preventive Cardiovascular Nurses Association. It has been such a joy bringing this series to life with you, so thank you. And a special thank you to our audience. Thank you for your eagerness to learn and innovate and engage. As a follow-up, you will receive an email with resources that are recommended from some of these panelists, but also the speakers from our first and second podcast in the series. Thank you for your patience with our technical difficulties as well. We will also send the video from Chairman Neal so you can watch it as well. As we've discussed throughout this series, there is still so much work to be done, and it begins with compassion and a willingness to understand. So I hope you find the resource we're sharing with you helpful in your efforts, and just like Dr. Fergus said, keeps the conversation going towards some actionable results. So thank you again for attending. Have a great day, and we will see you next time.